A'udhu billahi minash shaitanir rajeem. Bismillahir rahmanir rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Let us start our class by reciting a dua first. This is a masnoon dua that Rasulullah sallallahu alaihi wasallam used to recite for knowledge. Allahumma anfa'ani bima 'allamtani wa 'allimni ma yanfa'uni. And then he used to say, wazidni ilma. O Allah, benefit me with what you have taught me and teach me that which will benefit me. Wazidni ilma, and increase me in knowledge. Now this is your patient. She has come to your clinic. Her mother has brought her to your clinic, a little 4-year-old girl. The mother says she has shortness of breath, complains of tightness of her chest. She can't sleep properly at night because of this shortness of breath, and she's coughing all the time while trying to sleep. And when she's there, a strange sound is coming out in her breath when she's trying to exhale, throw the air out. A whistling or wheezing sound is coming out. This is, of course, a classical case of asthma. And the mother says this happens mostly when the spring season comes, when there's pollen in the air. So this is a case of asthma. Now, what happens in asthma? This is a normal bronchial tube. You see these muscles, smooth muscles, they are all relaxed. And you see this inner mucosal lining, and you see inside there is this open tube, open hollow tube, through which the gaseous exchange will take place. Oxygen will come in and carbon dioxide will leave, and this tube then opens in the alveoli. In this child's case, because she's an asthmatic, the pollen grains in the air have triggered an inflammatory response. And what happens in this inflammatory response? 3 things happen. Number 1, you can see that her smooth muscles have tightened, and so this has restricted the space inside the bronchi. Number 2, here you see that the mucosa is not swollen. This is the depth of the mucosa. Look at the mucosa out here. It is swollen so much, and when the mucosa swells up because of inflammation, then the inner open space inside the hollow tube, that is the inner diameter, gets reduced drastically. So that's the second thing which has happened in asthma. Third thing which has happened in asthma is that the inflammation causes the release of mucus. So this mucus inside these respiratory passages further reduces the open area of the tubes, and hence the gaseous exchange is reduced drastically. Very little oxygen can come into her alveoli, and very little carbon dioxide can escape from her alveoli, and hence that terrible position in which the child was in. So what do we find in acute asthma? We find in acute asthma that the pH, you see, from being normal, it goes on reducing until in severe asthma, the pH is very low, giving rise to acidosis in the child. What happens to the PCO2, the partial pressure of carbon dioxide? We can see because the carbon dioxide is being retained inside her body and very little is being thrown out, so the PCO2 becomes high. What happens to the bicarbonate? The bicarbonate is not involved in this initially, but later on it will come into play as a compensation for the respiratory acidosis, and so we find that the bicarbonate levels also become low here. What happens in this patient? The patient's respiratory rate becomes more than 25 because she's trying to breathe more, although she's unable to take in enough oxygen and throw out enough carbon dioxide. And she has tachycardia also nearly more than 110 beats per minute. So let us see this in more detail, asthma with respiratory acidosis. In respiratory acidosis, cellular respiration produces carbon dioxide continuously, right? In asthma, this carbon dioxide cannot be removed. So there is reduced ability of the lungs to remove this carbon dioxide. And hence the carbon dioxide will go on accumulating rapidly inside the body. When this carbon dioxide goes on accumulating inside the body, then it causes an increase in the partial pressure of carbon dioxide inside the body. So this is called hypercapnia. And we all know that you've all studied the Henderson-Hessel-Walsh equation, that in order to maintain the pH, the ratio between bicarb and carbon dioxide needs to remain constant. And we all know that the bicarbonate ions are 20 times more than the carbonic acid in the blood. And when this is 20 times more, then the pH remains normal at 7.35 to 7.45, because the pKa, of course, is a constant number, and hence the pH of the plasma depends mostly upon this ratio between bicarb ions and carbon dioxide. So as the carbon dioxide goes on increasing, as a compensation, the bicarb also needs to go on increasing. Initially, we had seen in the previous slide that the bicarbs had become low. Why? Because they were trying frantically to control this change in pH. But later on, when the compensatory mechanism sets in, then the bicarb increase along with the increase in carbon dioxide. So in a frantic attempt to keep this ratio normal, so that the pH can also become normal. But out here, as the carbon dioxide goes on increasing, the bicarbonate goes on reducing in order to try to maintain the pH, so the pH goes on reducing in case of asthma with respiratory acidosis. Learning objectives for today's class: the importance of pH regulation. Why does the pH need to remain within this narrow limit of 7.35 to 7.45? Then today's class, because this is the respiratory module, so we'll be focusing mostly on the respiratory causes of pH disturbances, that is respiratory acidosis and respiratory alkalosis. First, we will discuss how respiratory system regulates the pH, and then we'll discuss its abnormalities, which can lead to respiratory acidosis and respiratory alkalosis. And in both of these, we will first see the causes of respiratory acidosis or alkalosis, what investigations we do, that is, what are the changes in ABGs by which we can diagnose respiratory acidosis or respiratory alkalosis, and then how do we know that compensation has taken place in the body? What are the changes in the ABGs, the arterial blood gases, when compensation has set in respiratory acidosis or alkalosis? So this is today's topic for discussion. Now, as you can see, what is the importance of pH regulation? Small changes in pH can produce major havoc in the body. Why? Because most enzymes function only within narrow pH ranges. We have studied enzymes previously, and we know that all enzymes have a very, very narrow range of pH in which they can function maximally. A little change here or a little change there can drastically affect the function of the enzymes. Secondly, acid-base imbalance can also affect the electrolytes in our body, especially potassium. And if there is hyperkalemia or hypokalemia, it can have a drastic influence on the myocardium, leading to death. It can cause a cardiac standstill in systole or cardiac standstill in diastole, depending upon whether the potassium level has increased or decreased. And this is very closely related to the hydrogen ion concentration in the blood. Also, pH changes can affect the activity, the functions of the hormones in the body. In this picture, you can see that the bicarbonate needs to be 20 times that of carbonic acid. Then only is this delicate balance of pH maintained, that the pH then remains within this narrow limit of 7.35 to 7.45. If the pH falls to below 7.35, it is called acidosis. And this can remain up till the patient can remain alive up till a pH fall of 6.9. However, when the pH falls to below this, then death takes place. Similarly, because now the enzymes cannot function, hormones cannot function, potassium levels are going all haywire, and so this can lead to death of the patient. Similarly, if the pH rises above 7.45, this is called alkalosis. The patient can withstand this alkalosis only up till a pH of 8. Any rise in pH above 8 can lead to death of the patient. And all this is dependent upon such a fine balance between carbonic acid and bicarb, meaning the ratio needs to be 1:20. Effects of pH change on cells. Acidosis and alkalosis, these are not diseases per se. I mean, we cannot make the diagnosis that this patient is suffering from acidosis. This is the diagnosis. No. Acidosis and alkalosis are the results of a wide variety of disorders, meaning a lot of conditions can lead to acidosis and alkalosis. So acidosis and alkalosis are not diagnoses per se, they are just the reflections of diseases. pH changes have dramatic effects on normal cell function. They can change the excitability of nerve and muscle cells. They can influence the activity of enzymes, and they can influence potassium levels. And potassium level changes also can have a very drastic effect on the body's function. How is pH regulated? If there is a little alteration of pH in either direction, acidosis or alkalosis, the first line of defense are the buffers found in the blood. They come into action within seconds. Second line of defense is the respiratory regulation. This comes into action within minutes, at most within 12 to 24 hours. That's it. So these are the two instant reactions of the body to changes in pH. First line of defense, blood buffers, and then second line of defense, respiratory regulation. However, if the acidosis or alkalosis goes on for a longer time, then the third line of defense comes into play. This kicks in a few days, but it is more permanent. This is the renal regulation. The kidneys start functioning, altering the amount of bicarb ions they are retaining within the body or throwing out, or retaining or throwing out the number of H+ ions in the body. So this is how the kidneys function. So the pH balance is regulated by the chemical buffer system, which acts immediately, meaning the body buffers. Here you can see the bicarbonate buffer. As soon as there is acidosis in the body, that is hydrogen ions start rising, the bicarbs that are present in your blood, the bicarbonate buffer system, it immediately starts sapping up, it starts reacting with this hydrogen to form carbonic acid, and carbonic acid is then split by the enzyme carbonic anhydrase into water and carbon dioxide, and then that carbon dioxide is blown out through the lungs. So that is how the buffer system in the blood acts. The respiratory center in the brain stem gets stimulated within 1 to 3 minutes, causing an increase or decrease in the rate and depth of respiration. And when there is an increase in the rate and depth of respiration, more carbon dioxide is thrown out of through the lungs, and that is how the amount of carbonic acid is reduced, and that is how it reduces hydrogen ion concentration. And in case of alkalosis, then again the respiratory center in the brain stem in the pons and medulla comes into action, and it stops, it reduces the rate and depth of respiration in an effort to retain carbon dioxide in the blood, so that hydrogen ions can be retained in the blood to combat the alkalosis that is taking place. So this respiratory center in the brain stem functions in 1 to 3 minutes. And then the third mechanism to come into function is the renal mechanism. This takes hours or days to come into action, but this action is more permanent. So today let's just concentrate on the respiratory regulation of pH. What are the functions of the respiratory system? The function of the respiratory system is to exchange oxygen from air. The respiratory system takes in oxygen and gives it to the bloodstream, and from the blood it passes on to the cells. Secondly, it deals with carbon dioxide. The cells throw out carbon dioxide into the blood. That carbon dioxide from the blood goes into the lungs, and the lungs' job is to throw out that carbon dioxide into the air. So this gaseous exchange of taking in oxygen, throwing out carbon dioxide is the chief function of the respiratory system. But through this system, the respiratory system also regulates the pH of the blood by retaining more carbon dioxide or throwing out more carbon dioxide. And besides this, of course, the respiratory system is also essential for speaking, because throwing out air through the vocal cords, it causes vocalization and speech, and the protection of the alveoli. So all these are functions of the respiratory system. And this is what is happening in the respiratory system. Oxygen is coming in, carbon dioxide is being thrown out. This oxygen then moves on to the bloodstream through the pulmonary circulation, and it goes to the heart. And the heart then pumps it into the systemic circulation, and this oxygen then goes to the cells for cellular respiration. Cells then give out carbon dioxide, which again moves through the systemic circulation to the heart, and then from the heart it moves on through the pulmonary circulation to the lungs, The alveoli of the lungs then blow out this carbon dioxide into the air. So this is the function of the respiratory system. How is the respiration regulated? The objective of regulation of respiration is to maintain normal levels of oxygen and carbon dioxide in the arterial blood. There are three basic elements through which the respiratory system controls this amount of oxygen and carbon dioxide in arterial blood. First of all, sensors. There are chemoreceptors which are found, and there are two types of chemoreceptors, central chemoreceptors and peripheral chemoreceptors. And there are pulmonary receptors and other receptors. All these can detect the amount of oxygen and carbon dioxide in the blood and the pH in the blood. And they then, if they detect any abnormality, they send input to the central control. Central control is in the brain stem, pons and medulla, some also in the cortex and other parts of the brain. Then from this central control house, the output goes to the effectors. The effectors are the respiratory muscles, the diaphragm, abdominal muscles, accessory muscles, to increase or decrease the rate and depth of respiration. So how does the respiratory system regulate pH? It eliminates carbon dioxide from the blood and replenishes the stores of oxygen. Where is this carbon dioxide coming from? It has been generated by cellular respiration, so it is coming from the cells. This carbon dioxide from the cells, it enters the red blood cells in the bloodstream. And in the red blood cells, it is converted to bicarbonate, and in this form, it is transported in the plasma to the lungs. As you can see out here, the carbon dioxide has been breathed out by the cells into the bloodstream. In the bloodstream, it enters the RBCs. In the RBCs, it reacts with water found inside the RBCs, and in the presence of this enzyme, carbonic anhydrase, carbon dioxide and water react together to form carbonic acid, H2CO3. This carbonic acid then splits up to form the proton, H+, and bicarbonate ion. And in this form, it is transported in the plasma. This goes out in the plasma in exchange for potassium coming inside, and this is then transported in the plasma to the lungs. This is the Henderson-Hasselbalch equation. pH is equal to pKa plus log of conjugate base over weak acid. This applies to all buffer systems. And the buffer system's pKa is of course fixed. So the pH basically depends upon the ratio between the conjugate base and the weak acid. And in case of the plasma, the main buffer being the bicarbonate buffer, it depends upon the ratio between the bicarbonate ions and carbonic acid. Normally, this ratio is 20:1. That is, there are 20 times more bicarbonate ions, which is called the basic cess, compared to the amount of carbonic acid. The log of 20:1, when that is added to the pKa of bicarbonate buffer system, is 6.1. When this is added to 6.1, the answer pH is always 7.4. So what do you think will be the log of 20:1? The log of 20:1 will be 1.3. So when you add 1.3 to 6.1, it will become 7.4. Like we had earlier discussed, that the bicarbonate ratio to carbonic acid needs to be 20:1 to maintain this very delicate balance, so that the pH remains between 7.35 to 7.45. Any decrease in pH is called acidosis, any increase in pH is called alkalosis. So this is how carbon dioxide is transported in the blood. Carbon dioxide is dissolved in the blood plasma as the bicarbonate ion. You can see this tissue cell out here breathing out carbon dioxide. So the carbon dioxide has come from the cells. It has dissolved in the plasma. Some of it goes inside the RBC, and it combines with HB, with the hemoglobin also. And some of it combines with the water inside the RBC to form carbonic acid. This carbonic acid then, and the enzyme responsible for this change is carbonic anhydrase. This carbonic anhydrase is also responsible for splitting the carbonic acid into protons, H+ ions and bicarb. and the bicarb ion then goes out in the plasma, and because it is a negatively charged ion, it goes out in the plasma in exchange for another negatively charged ion, that is the chloride ion, which enters the plasma. Hydrogen ion, which is a positively charged ion, if this is in excess, as in acidosis, if there is an excess of it and it comes out in the plasma, then what happens? Then this will be exchanged with potassium ions. So if there's a lot of hydrogen ions in the plasma, in case of acidosis, they will enter the cell, and in exchange, what will happen? The potassium, which is another positively charged ion inside the cell, will then come out. So potassium K plus exchanges with hydrogen because they are both positively charged ions, and the chloride, which is a negatively charged ion, exchanges with bicarb, which is also a negatively charged ion. So the respiratory system offers the second line of defense. It acts in a short time, in minutes, and at most it takes 12 to 24 hours to come into action. Carbonic acid that is produced gets converted to carbon dioxide, and it is excreted by the lungs. So this bicarb that you had seen out here, when it reaches the lungs, what's going to happen? The reverse reaction, that this bicarb ion will again react with hydrogen ion to form carbonic acid, which will again go back and form carbon dioxide and water, and this carbon dioxide will then be thrown out by the lungs. So this respiratory system is a very powerful system, but it works only with those acids which can be thrown out by the lungs, that is the volatile acids, meaning those which are in the gaseous form. It exhales carbon dioxide. So carbon dioxide and water together react to form carbonic acid, which then splits into the proton H plus and the bicarbonate ion, which is carried in the plasma. Body pH can be adjusted by changing the rate and depth of breathing. How? When we increase the rate and depth of breathing, more carbon dioxide is blown out by the respiratory system. So this becomes less, so this becomes less. So this reduces the acidosis. However, when the body pH has become very low, meaning when there is acidosis because of a lot of carbon dioxide that has been retained by the respiratory system, like we saw in the case of that little girl with asthma, she couldn't breathe out carbon dioxide, so carbon dioxide had gone on accumulating in her body, leading to a high level of carbonic acid, which leads to a high level of protons, leading to acidosis. Now, because her respiratory system is not functioning, so what will be the next system that will function to reduce this acidosis? It will be her kidneys, the renal system. Renal system will now have to come into action to throw out this excess H plus ions. So this is what we've seen in the respiratory regulation of pH. Carbon dioxide and water react together to form carbonic acid, which then splits into the hydrogen ion and the bicarb ion. Carbonic anhydrase is important in carbon dioxide transport in the blood. This enzyme is found in the red blood cells. It is also found in the gastric mucosa, the pancreatic cells, and the renal tubules. What is the job of carbonic anhydrase? It catalyzes the interconversion of carbon dioxide and carbonic acid. So it changes carbon dioxide to carbonic acid and carbonic acid back to carbon dioxide. That's both ways. So what is the role of the respiratory system in acid-base balance? Alterations in ventilation alter the rate of excretion of carbon dioxide or the retention of carbon dioxide. When there is an alteration in the rate of carbon dioxide excretion, then this will cause an alteration in the pH through the carbonic acid that has been retained. When there is a lot of carbon dioxide that has been retained, then a lot of carbonic acid will be retained, a lot of hydrogen ions will be generated, giving rise to acidosis. This way, the respiratory system can help control non-respiratory acidosis and alkalosis. So when will the respiratory system come into function? When it is intact. Of course, if the respiratory system is at fault, like in case of asthma, then it can't function. Then it is itself responsible for causing acidosis. Or if it is so damaged in such a way that there is excessive throwing out of carbon dioxide, then again the respiratory system will not be able to help, because this itself is responsible for causing respiratory alkalosis. In this case, the blood buffers will come into action and the kidneys will come into action. But if there is metabolic acidosis or alkalosis, then in that case, the lungs will come into action if the lungs are normal. So I hope you understand this concept, that if the lungs are normal, then they are the second line of defense. And they help to control metabolic acidosis and alkalosis. But if the lungs are abnormal, then they can't function. Then the kidneys come into action and they help to control respiratory acidosis or alkalosis. How do we measure the blood gases, arterial blood gases of a patient? This is the equipment through which we do it. It's called a blood gas analyzer. And this ABG's arterial blood gas test, this is the most common test performed on patients in intensive care units. Why? Because this information is vital when caring for patients with any sort of critical illness or respiratory disease. We need to know if the patient is in acidosis or alkalosis so that it can be corrected. A small volume of blood is drawn from the radial artery. Now please be careful. This is arterial blood. So we have to be extremely careful when drawing this blood, lest we puncture the radial artery and the blood starts gushing out. And also we cannot introduce any infection in any case because we are entering the artery. So one has to be extra careful. We can't introduce infection even into veins. But here we are dealing with artery which is supplying blood to a certain part of the body. So we have to be very, very careful. Partial pressure of the arterial gases is then measured in this sample, the radial arterial blood sample, oxygen. And this blood gas analyzer tells us the partial pressure of oxygen in this blood sample, partial pressure of carbon dioxide. It also tells us the pH, and it also tells us oxygen saturation. What it does not tell us is the amount of carbonic acid, H2CO3, that we have to calculate ourselves. How do we do that? We take the PCO2 multiplied by this figure, 0.0301, and that will give us the value of carbonic acid. These are the normal ABGs. Normal pH value is 7.35 to 7.45, but in some laboratories it's also taken as 7.37 to 7.44. Partial pressure for carbon dioxide is either, you can remember it as 35 to 45 millimeters of mercury, but usually it is written as 34 to 44 millimeters of mercury. Partial pressure of oxygen is 65 to 105 millimeters of mercury. The standard amount of bicarbonate is 22 to 26 millimoles per liter. And oxygen saturation is 95 to 98%. And therefore, if you want to calculate the carbonic acid level, you have to multiply the PCO2, whatever PCO2 is out here, by this figure, 0.0301. How do we interpret ABGs? For interpreting ABGs, three things are very crucial: the pH of the blood, the PCO2, and the bicarb levels. pH of the blood. A normal pH is, let's say, 7.35 to 7.45. Anything less than 7.35, we call it acidosis. So the acidosis could be, there are 4 different types of disturbances in the pH. 2 are related to the respiratory system and 2 are not related to the respiratory system. So those 2 which are related to the respiratory system, we call them respiratory acidosis and respiratory alkalosis. Unrelated to the respiratory system, we call them metabolic acidosis and metabolic alkalosis. In respiratory acidosis, of course, the pH will be lower than 7.35. And in respiratory alkalosis, the pH will be higher than 7.45. In metabolic acidosis, because it's acidosis again, the pH will be less than 7.35. And in metabolic alkalosis, the pH will be more than 7.45. So by looking at the pH, we can say if the patient has acidosis or alkalosis. Any pH less than 7.35, we call it acidosis. Any pH greater than 7.45, we call it alkalosis. Now the second step is to find out whether this acidosis and alkalosis are due to respiratory disturbances or non-respiratory disturbances. That is, whether it is respiratory acidosis or alkalosis, or it is metabolic acidosis and alkalosis. For that, we need to look at the patient's carbon dioxide, partial pressure of carbon dioxide, PCO2, in millimeters of mercury. The normal PCO2 is 35 to 45 millimeters of mercury. So if this PCO2 is less than 35 millimeters of mercury, then we call it respiratory alkalosis. If this PCO2 is more than 45 millimeters of mercury, we call it respiratory acidosis. So any abnormality, initial abnormality in PCO2, then the trouble lies in the respiratory system, because carbon dioxide is breathed in and breathed out only through the respiratory system. And here, why is there an inverse relationship? We know that an accumulation of carbon dioxide in the blood when the patient is unable to breathe, like that little girl with asthma, which will lead to an accumulation of carbon dioxide in the blood. When there's a lot of carbon dioxide accumulated in the blood, it will react with hydrogen, it will react with CO2, will react with water to form what? Carbonic acid. And that carbonic acid is an acid. It will split into H plus ions. So when H plus ions become high, it leads to acidosis. So PCO2, when it becomes high, it means there is more acid accumulation, and hence the pH will be low in this case. So you can see this inverse relationship between the pH and PCO2. This relationship is always inverse. The more the accumulation of carbon dioxide in the blood, the more the accumulation of carbonic acid, H2CO3, and the lower the pH because of this acidosis. The reverse holds true for respiratory alkalosis, meaning the less the carbon dioxide in the blood, the less the acid in the blood, H2CO3, and the less the acid in the blood, the less the hydrogen ions. So the higher the pH. So again, what do you see? There is an inverse relationship between the pH and the PCO2. So this will show us if there is an alteration in the PCO2 less than 35, it will be respiratory alkalosis. More than 45 millimeters of mercury will be respiratory acidosis. If the PCO2 is normal, then it means that there is no respiratory disturbance, then it is a metabolic disturbance, right? So normal PCO2 rules out respiratory disturbance. In respiratory acidosis and alkalosis, the PCO2 is always either less than 35, then it will be respiratory alkalosis, or if it is more than 45, then it will be respiratory acidosis. Now we move on to the next component of the ABGs, which is the bicarbonate ion. Bicarbonate ion is related to metabolic acidosis and alkalosis. Whenever the bicarbonate ion becomes low, then there is metabolic acidosis. Whenever the bicarbonate ion becomes high, then it is metabolic alkalosis. In this case, the PCO2 is normal. Why? Because there is no respiratory component, no respiratory disturbance. So the PCO2 is normal. However, the bicarb is the one that is above or below normal. Why do you notice this strange phenomena that in case of metabolic acidosis and alkalosis, pH is directly related to the bicarb ion? When the pH falls in metabolic acidosis, bicarb ion also falls. When the pH rises in metabolic alkalosis, the bicarb ion also rises. Whereas in case of respiratory acidosis, when the pH falls, the PCO2 rises. When the pH becomes high in respiratory alkalosis, PCO2 becomes low. So here in respiratory conditions, you find an inverse relationship between the pH and PCO2. And in case of metabolic disturbances, metabolic acidosis and alkalosis, you find a direct relationship between the pH disturbance and the bicarb disturbance. Reason, look at the Henderson-Hessel-Balch equation. What had we discussed earlier? pK is a constant value. So pH basically is a reflection of the ratio between bicarbonate and carbonic acid. pH is directly related to bicarb. So it has a direct relationship with bicarb. Higher the bicarb, higher the pH. You can notice it out here. Higher the bicarb, higher the pH. Lower the bicarb, lower the pH, because there is a direct relationship. Lower the bicarb, lower the pH. However, when it comes to carbonic acid, because remember carbon dioxide is the reflection of carbonic acid, because carbon dioxide will very soon react with water in the presence of carbonic anhydrase to form carbonic acid. Carbonic acid, on the contrary, has an inverse relationship with pH. So the higher the carbonic acid, the lower the pH. Lower the carbonic acid, the higher the pH. This is what you notice out here. Higher the carbonic acid, lower the pH. Lower the carbonic acid, higher the pH. I hope this is clear now that there's an inverse relationship between pH and PCO2, because PCO2 is a reflection of carbonic acid, H2CO3, but there's a direct relationship between pH and bicarb ion, because pH and bicarb have a direct relationship. So, I hope now you can diagnose respiratory pH disturbances by looking at the ABGs. Acidosis means what? That the pH is less than 7.35, whether it is metabolic or respiratory. Alkalosis means what? That the pH is higher than 7.45, whether it is metabolic alkalosis or respiratory alkalosis. Now, once you've determined whether it is acidosis or alkalosis, now the next step is to find out whether it is metabolic acidosis or respiratory acidosis. For that, what will you look at? If there is carbonic acid which has become very high, leading to low pH, then you call it respiratory acidosis. Or if the carbonic acid is low, giving rise to high pH, then you call it respiratory alkalosis. Because remember, there's an inverse relationship between carbonic acid and pH. Similarly, when you move on to the metabolic component, this has a direct relationship. So the lower the bicarb, the lower the hydrogen ion concentration and the lower the pH, and this gives rise to acidosis, then this is called metabolic acidosis. And if you find a high amount of bicarb leading to a high pH, then this is called metabolic alkalosis. This is, of course, the primary disturbance that we are talking about. Again, this is a reflection of the Henderson-Hessel-Walsh equation. pH has a direct relationship. It is directly, it has a direct relationship with bicarb ion, and pH is inversely proportional to the carbonic acid. So these are the 4 primary acid-base disorders, and all are reflections of the Henderson-Hessel-Walsh equation. So if you find a low pH, what will you call it? Yes, acidosis. And then you move on to look at the bicarb levels. If the bicarb levels are also low, then what will you call it? Metabolic acidosis. If the pH is high and the bicarb is also high, because bicarb has a direct relationship with pH, see out here again, Henderson-Hessel-Walsh equation. So if the pH is high, you call it alkalosis, and if the bicarb is also high, then you call it metabolic alkalosis. If the pH is low, you'll call it acidosis. And if you find that the PCO2 is high, because there is an inverse relationship between pH and carbonic acid, and carbon dioxide is a reflection of carbonic acid. So if the pH is low and carbon dioxide is high, you are going to call it acidosis. What type of acidosis? Respiratory. So this is respiratory acidosis. If the pH is high and the PCO2 is low, again inverse relationship. If the pH is high, you're going to call it alkalosis. And if it is due to a low PCO2, then it is the respiratory component that is at work. So you call it respiratory alkalosis. So what is the primary defect in acidosis and alkalosis? Acidosis means low pH. So whenever you find low pH, you'll call it acidosis. Whenever you find high pH, you'll call it alkalosis. Then in order to differentiate whether it is respiratory acidosis or metabolic acidosis, look at the H2CO3 or the carbon dioxide levels. If the carbon dioxide levels are altered, if they are high, then you call it respiratory acidosis. Similarly, if the carbon PCO2 or the carbonic acid level is low and the pH is high, then you call it respiratory alkalosis. And then you look, and if this is not so, if the carbonic acid or the PCO2 is normal, but the metabolic component is altered, that is the bicarb level. If the bicarb level is low and the pH is low, then you call it metabolic acidosis. If the bicarb level is high and pH is high, you call it metabolic alkalosis. Again, please keep in mind your Henderson-Hessel-Walsh equation, that pH has a direct relationship with the bicarb ions and it has an inverse relationship with carbonic acid, and carbonic acid is a reflection of carbon dioxide, PCO2. Now let us see how it alters pH. So let's say that you have to determine the pH of this patient with asthma. Again, write down your Henderson-Hessel-Walsh equation. pH is equal to pK plus log bicarbonate concentration divided by carbon dioxide divided by H2CO3 carbonic acid concentration. pK is of course fixed for the bicarbonate ion, it is 6.1. However, your laboratory findings reveal that bicarb is 20 millimoles per liter, so you write here 20 millimoles per liter. Normal is of course 22 to 26, so you find that the bicarb level is low. If the bicarb level is low, what sort of a pH disturbance will you call it? Yes, it is the metabolic component that is at work. And the carbonic acid H2CO3, you find that this has also become higher than normal. It is 5 millimoles per liter. So you find that the bicarb component is normal. It is 20. It is a little less. So that means that compensation is coming into play. And what is the basic disturbance here we find is in the H2CO3, which has become high. That is, the PCO2 has become high. So you find the log with a base of 10 of 20 divided by 5. This answer is 0.6. The log of 4, 20 by 5 is 4. Log of 4 is 0.6. When you add 6.1 to 0.6, you find that this little girl's pH is 6.7. So she is suffering from respiratory acidosis because normal pH should be 7.35 to 7.45. And this little difference that you're finding in here in the bicarb component, which has fallen slightly, this is showing compensation. We'll soon see what compensation is all about. So let us discuss respiratory acidosis in a little more depth. Volatile acids like carbonic acids are managed primarily by respiratory control, whereas non-volatile acids like keto acid, lactic acid, they are managed mostly by renal control and by buffer systems. So what is respiratory acidosis? In respiratory acidosis, because it is acidosis, pH will be low. Because the respiratory component is at work, so PCO2 will be altered, will be different from normal. How will it be different? If the pH is low, it means there is lots of carbon dioxide in the blood, leading to lots of H2CO3 in the blood, the carbonic acid, and so there'll be if there's a lot of carbon dioxide, pH becomes low. And this happens in respiratory insufficiency, like asthma, where carbon dioxide is not being exhaled out properly. It also happens in chronic obstructive pulmonary disease due to any reason, long-term infections or smoking. Long-term smoking can lead to obstruction of the pulmonary alveoli, the bronchi, etc. So chronic obstructive pulmonary disease, or narcotic poisoning, which acts on the central mechanism and it reduces the rate and depth of breathing. So in all these cases, there's going to be hypoventilation, meaning not enough carbon dioxide is being thrown out of the body. So carbon dioxide starts accumulating in the body. This increases the PCO2. And when this increases, when the PCO2 is increased, the carbon dioxide reacts with water in the presence of the enzyme carbonic anhydrase to make H2CO3, carbonic acid. So carbonic acid levels go on increasing inside the blood. When the acid level goes on increasing, then the pH starts to fall, and this is called respiratory acidosis. So respiratory acidosis is the acid-base disturbance initiated by an increase in carbon dioxide retention in the body, that is the partial pressure of carbon dioxide, PCO2. The level of PCO2 is determined by the interaction of two factors: the rate of carbon dioxide production, either too much carbon dioxide is being produced in the body, and the rate of alveolar ventilation, or too little is being thrown out of the body. So PCO2 is determined by the ratio between the amount of carbon dioxide being produced in the body. For instance, if there are large tumors in the body, a lot of cells throwing out a lot of carbon dioxide, and if the respiratory system is not adequately functioning, this can also lead to an accumulation of carbon dioxide in the body. And also alveolar ventilation. If the alveoli are not ventilating properly, like in asthma or chronic obstructive pulmonary disease, then in this case, of course, carbon dioxide will go on accumulating in the body. K is a constant, of course. Causes of respiratory acidosis: increase in arterial PCO2 by one of three possible mechanisms: presence of excess carbon dioxide in the inspired gas, or decreased alveolar ventilation, or increased production of carbon dioxide by the body. Respiratory acidosis is a medical emergency in which decreased ventilation causes increased accumulation of carbon dioxide in the blood, and this ultimately leads to decrease in the pH level. During alveolar hypoventilation, there's an increase in carbon dioxide. This leads to an increase in partial pressure of carbon dioxide in the blood, PCO2. Acidosis refers to disorders that lower the pH of the cells and tissues to less than 7.35. And acidemia, emia means blood, refers to an arterial pH which falls below 7.3, meaning 7.35 to 7.45 is the normal pH. Acidosis means in the cells the pH has fallen. Acidemia means in the arterial blood the pH has fallen. Acute respiratory acidosis, the PCO2 is elevated above the upper limit of the reference range. And the carbon dioxide, meaning the carbon dioxide has started to accumulate. It has become more than 45 millimeters of mercury with an accompanying acidemia, so the pH has fallen to less than 7.35. When does it happen? What are its causes? Occurs when an abrupt failure of ventilation occurs. Failure in ventilation may be caused by depression of the central respiratory center, or when the central respiratory center in the brain stem, medulla and pons, when this is depressed by narcotics or any other reason, then what happens? There is a reduction in the rate and depth of breathing. So carbon dioxide starts to be retained in the body. Or inability to ventilate adequately due to neuromuscular diseases, or airway obstruction, which is related to asthma or chronic obstructive pulmonary disease, etc. So these are the causes of respiratory pH disturbances which lead to respiratory acidosis: hypoventilation, chronic obstructive pulmonary disease, airway obstruction, drug overdose which affects the center, chest trauma when the muscles are not acting enough to throw out carbon dioxide, pulmonary edema if there's a lot of water collected inside the alveoli, so they cannot act sufficiently to cause this gaseous exchange, or neuromuscular disease where again the gaseous exchange is being disturbed. So respiratory acidosis could be due to airway obstruction, due to bronchitis, bronchospasm, emphysema. Emphysema means that the alveoli, the wall between the adjoining alveoli breaks down, so there's a lot of gas accumulated inside the alveoli, and the alveoli have become one big mass. Or lung diseases like fibrosis or pneumonia, or respiratory center depression by anesthetics or sedatives, or due to cerebral trauma or due to tumors in the brain, or extrapulmonary thoracic diseases like kyphosis and scoliosis, meaning the vertebral column is pressing on the lungs, not allowing adequate ventilation to take place. Neural diseases like poliomyelitis, paralysis of the respiratory muscles. The objective of the respiratory system is to maintain normal levels of PO2 and PCO2 in the arterial blood, and we have already discussed that there are three basic elements by which this happens. Chemoreceptors send their input to the central control system present in the pons and medulla, and they then affect the respiratory muscles, causing a change in the rate and depth of breathing. So this is what happens in respiratory acidosis. We will not deal with metabolic acidosis at the moment. We are just concerned with respiratory acidosis. pH starts to fall to less than 7.35. Because of hypoventilation, it could be due to drug overdose or pulmonary edema, or chest trauma, neuromuscular diseases, airway obstruction, chronic obstructive pulmonary disease. In all these cases, pH becomes low, leading to acidosis. Carbon dioxide becomes high. So this is called respiratory acidosis. What are the clinical features and symptoms of respiratory acidosis? Initial signs of acute respiratory acidosis include headache, anxiety, blurred vision, and the patient becomes very restless because he can't breathe properly, and he becomes very anxious. His vision starts to blur and he develops a headache. If you don't give him treatment immediately, then his symptoms will worsen. He will not be able to sleep. He will feel very sleepy, but he'll be very anxious, and he may start flitting into and out of unconsciousness. So he becomes in a very sleepy sort of state. There are tremors taking place and delirium. Principal effect of acidosis is depression of the central nervous system. So this is what happens in acidosis, how it reduces the synaptic transmission. Patient starts feeling weak, there's generalized weakness, CNS functions get deranged, and if the acidosis is very severe, patient becomes disoriented in time, space, person. Finally, he slips into coma and dies. Clinical features of respiratory acidosis vary according to the severity of respiratory acidosis and how long it has lasted, that is the duration. What is actually the underlying disease and whether there is hypoxemia also along with it. So all these factors will determine the severity of the manifestations of symptoms in the patient. Hypercapnic encephalopathy include irritability and inability to concentrate, headache, anorexia, apathy, confusion, patient is combative, he wants to fight people. If you will start to give him oxygen, he may fight with you and try to pull out that oxygen. He starts getting hallucinations, he's in a state of delirium. There may be transient psychosis, progressive narcosis, and ultimately he slips into coma. When you check out when you do his retinal examination, you can find papilledema. And you also find motor disturbances. There can be myoclonic jerks, flapping tremors, even seizures. The occurrence and severity of neurological manifestations depend on the magnitude of hypercapnia, how much of the carbon dioxide has been retained inside his blood, the rapidity with which it develops, the severity of the acidemia, and the degree of the accompanying hypoxemia. So these are the symptoms of acidosis. There will be headache, sleepiness, confusion, loss of consciousness, coma. In his muscles, there will be seizures, weakness, he may get diarrhea, and in his respiratory system, he'll be short of breath, he'll start coughing. When you look at his heart, there will be arrhythmias, increased heart rate, tachycardia. His stomach, there'll be nausea, there may be vomiting. And this patient will complain, I can't catch my breath, I can't breathe enough. His pH will be low, his PCO2 will be high. pH will be less than 7.35, PCO2 will be higher than 45 millimeters of mercury because carbon dioxide is being retained by his lungs due to hypoventilation, and it will also lead to hypoxia. So he has rapid shallow breaths, he's taking rapid shallow breaths, his blood pressure may drop. And then why? Because there may be vasodilation. He has dyspnea, headache, hyperkalemia. The more the H plus ions in the blood, remember we had spoken about this earlier, H plus is a positive ion. The more it keeps on exchanging with the K plus, the positively charged ion inside the cell, so the more the H plus in the extracellular fluid, they'll start going inside the cell, and the K plus ion, the potassium positively charged ions, will start coming out of the cell, giving rise to hyperkalemia. And this hyperkalemia will affect the heart, giving rise to dysrhythmias. Also, this patient will experience drowsiness, dizziness, disorientation, muscle weakness, hyperreflexia, and all this will be due to drug overdose or anesthesia or chronic obstructive pulmonary disease, pneumonia, lack of respiratory stimuli, all these, asthma, all these are the causes of respiratory acidosis. So we had been discussing about the effect of the H plus ion on the potassium ion. In acidosis, we know that there is a lack of the pH becomes low. In alkalosis, pH becomes high. In acidosis, hydrogen ions will become high. When there are a lot of hydrogen ions in the extracellular fluid, they'll start moving inside the cell, and in exchange, the positively charged potassium ion moves out. So in case of acidosis, there is always hyperkalemia. Opposite is true in case of alkalosis. In case of alkalosis, there is a lack of hydrogen ions outside the cell, so they can't move inside the cell. So the potassium positively charged potassium ion from inside the cell can't move outside, and so there is hypokalemia in case of alkalosis. When there is hyperkalemia, hyperkalemia is accompanied with acidosis. So in case of hyperkalemia of acidosis, what do we find? What sort of cardiac changes? It's going to slow down the heart rate, and there will be ECG changes also, tall peak T waves, short QT intervals, long PR interval, widening QRS complex, all because the heart rate has slowed down. When there is a severe hyperkalemia, this can lead to decreased strength of contraction of the heart. So the heart becomes dilated and flaccid, and ultimately there is cardiac standstill in diastole. So respiratory acidosis occurs when the lungs cannot remove enough carbon dioxide. Excess carbon dioxide makes the blood more acidic because of excess formation of H2CO3, carbonic acid. This is because the body must balance the ions that control pH. Normal pH is 7.35 to 7.45. In respiratory acidosis, it becomes lower than 7.35. Normal PCO2 is 35 to 45 millimeters of mercury. In respiratory acidosis, it becomes higher than 45 millimeters of mercury. Normal bicarb is 22 to 24 milliequivalents per liter. In respiratory acidosis, initially bicarb will become low because it is trying to combat the effects of the respiratory acidosis. Now let us discuss the compensation mechanisms of respiratory acidosis. The first line of defense are the chemical buffers found in the bloodstream. They are on the scene within seconds. They are already present in the tissue and they'll handle minor changes in acid-base balance. Then, if the defect is not due to the respiratory center, any other sort of pH disturbance in which the respiratory system is fine, there is no problem with it. On the contrary, there is metabolic acidosis or alkalosis. Then the second line of defense is the respiratory system. It will increase or decrease the rate or depth of respiration, retaining or eliminating the amount of carbon dioxide. This acts within minutes. Respiratory compensation can handle mild to moderate acid-base shifts. And then if the respiratory system is at fault, then the third line of action is the renal system. Renal bicarb will combat hydrogen losses and gains. This starts in hours to days, but it is more permanent. When the other two mechanisms fail, then ultimately the renal system slowly gets to work. This requires up to 5 days to complete all its work. So this is how respiratory acidosis is compensated. The pulmonary system, meaning the respiratory system and the renal system, will compensate for each other to return the pH back to normal. Lungs compensate for metabolic disturbances by altering the PCO2 levels by hyperventilation or hypoventilation, whereas the kidneys compensate for respiratory disturbances by altering the bicarb levels by reabsorbing or retaining or excreting the bicarb ions. So this is how it all works, feedback loop of respiratory control. If the blood pH is altered, then the PCO2 is also altered. Chemoreceptors sense this change. They send signals to the brainstem respiratory centers in the pons and medulla. They then send the response to the breathing muscles. Breathing muscles come into action to increase or decrease the rate and depth of respiration. So the alveolar ventilation rate and depth increase or decrease, and this brings back the blood pH, PCO2, PO2 back to normal. If there is decreased ventilation, there is increased arterial PCO2. So the blood pH falls. So the chemoreceptors in aortic and carotid bodies come into action. Sensory neurons send their information to the respiratory center in the medulla oblongata, and this then affects the spinal cord motor neurons, which affects the respiratory muscles, which increases ventilation. And this will then send a negative feedback back to reduce the arterial PCO2. Also, the increased arterial PCO2 leads to the plasma CO2 also rising. So this leads to CSF chemoreceptors in medulla oblongata being stimulated. They will also affect the respiratory center in the medulla oblongata, and a similar story will take place again. So this is the response to acid-base imbalance. Addition of hydrogen ions will cause the carbonic acid level to increase, and this will affect the lungs. The lungs will try to throw out carbon dioxide. The kidneys will also be affected by the secretion of extra H ions if there's a lot of H ions in the bloodstream. Other buffer systems will try to absorb this extra H plus ions. So this happens, for instance, the bicarbonate buffer, this acts to pick up the H plus ions. So this is the response to acid-base imbalance in the blood, response to acidosis. Normal acidosis And when the homeostasis is disturbed, when there's increased H plus production or decreased H plus excretion, so this leads to acidosis. Buffer system comes into play because the pH has decreased. So the first line of action are the buffer systems, and then there is of course the respiratory system, and then there is the renal system. They all come into action. Compensation of respiratory acidosis. Metabolic acidosis, how is it compensated? What happens in metabolic acidosis? pH becomes low and H2CO3 becomes high. Now, if H2CO3 has become high, what do you think should happen to the bicarbonate? The bicarbonate also needs to become high so that this ratio can be maintained. And so what can we expect? That the bicarb will also start to rise in case of metabolic acidosis. This is how compensation takes place. Similarly, if there is respiratory alkalosis, pH becomes high, then what happens to carbonic acid? It becomes low. So in this case, the bicarbs also need to become low. When both these become low, then the ratio tends to come back towards normal. So how does the body compensate for a low, for a high pH and a low carbonic acid level? By reducing the level of bicarbs also. So in respiratory alkalosis, bicarb levels also fall. So this is the compensation, the compensatory mechanism. So the compensation of respiratory acidosis, this is what happens in respiratory acidosis. So long as it is uncompensated, that is primary respiratory acidosis, we find that the pH becomes low, carbon dioxide becomes high, bicarb is unaffected. But when it starts getting partially compensated, pH remains low, carbon dioxide remains high, but the bicarb now starts to rise. And when it is fully compensated, then the carbon dioxide is also high, bicarb is also high, so the pH is brought back to normal. So this is what happens in severe respiratory acidosis due to severe asthma, pneumonia, hypoventilation, etc. What happens in respiratory alkalosis? In primary respiratory alkalosis, which is uncompensated, pH becomes high because carbon dioxide PCO2 has become low. Bicarb is unaffected in the primary stage. Then as it is partially compensated, pH remains high, carbon dioxide remains low, but the bicarb also starts to become low to bring back that ratio to normal. And when it is fully compensated, then what do we find? Carbon dioxide is also low, bicarb is also low, and it has managed to bring the pH back to normal. So this is what happens in compensated respiratory alkalosis due to hyperventilation, panic attacks, aspirin poisoning, etc. In all these cases, there is excessive respiration, increase in rate and depth of respiration, so it manages to blow out a lot more carbon dioxide than it is being poured out from the cells into the bloodstream. So this is the compensation for respiratory acidosis. Homeostasis is disturbed, so there's stimulation of arterial and CSF chemoreceptors. So there's respiratory compensation, there's decreased PCO2, and hemostasis is restored. Also, respiratory acidosis affects the renal compensation mechanism. So this affects the hydrogen ion secretion and the bicarb generation. So this is how homeostasis is restored. Buffer systems other than carbonic acid bicarbonate system also accept hydrogen ions. So this is respiratory acidosis, which is partially compensated. You can see that the pH, which normally should be 7.35 to 7.45, here it is still lower than normal. And so it hasn't yet been brought back to normal, so we call it partially compensated respiratory acidosis. What do you find in the partial pressure for carbon dioxide, PCO2? Normally it should be 35 to 45 millimeters of mercury. Here you find that it is much higher than that. What about the bicarb? 22 to 26 millimoles per liter is what they should be normally. Here you find that the bicarb have started to rise. As the carbon dioxide had risen, so the bicarb are also starting to rise. And when they have risen to an extent where the ratio is brought back to normal, then they'll manage to bring the pH back to normal. Then we will say that this is fully compensated respiratory acidosis. Now let's move on to the next topic for today, which is respiratory alkalosis. Respiratory alkalosis is the acid-base disturbance initiated by a reduction in PCO2 in the bloodstream. This occurs when there is excessive loss of carbon dioxide by hyperventilation of the lungs. So there is hypocapnia. Why? Because a lot of carbon dioxide has been blown out. There's excessive depth and rate of breathing, as in hysteria, as in different kinds of conditions like aspirin poisoning. All this affects the central mechanisms for breathing, and so the rate and depth of breathing increases. So a lot of carbon dioxide is thrown out of the lungs. This leads to hypocapnia. So hypocapnia develops when a sufficiently strong ventilatory stimulus causes carbon dioxide output in the lungs to exceed its metabolic production by the tissues. So carbon dioxide level becomes low in the blood. As a result, the partial pressure of carbon dioxide PCO2 falls. And when PCO2 falls, what will happen to the acid H2CO3? That will also become low. When acid becomes low, then hydrogen ion concentration will also fall. And when hydrogen ion concentration falls, so there is a decrease in the bicarbonate levels. So this is what happens in case of respiratory alkalosis. In respiratory alkalosis, there is increased pH, hence we are calling it alkalosis. And why do we call it respiratory? Because the disturbances in the carbon dioxide level in PCO2. pH becomes high, which means that PCO2 has become low. Because of a low PCO2, pH level has become high. And this is because of increased respiration due to anxiety, hysteria, hypoxia, anemia, pregnancy, etc. There is hyperventilation, so a lot of carbon dioxide is blown out, exhaled out, so there is a lack of carbon dioxide in the blood. So low PCO2. Low PCO2 means low H2CO3 levels. Low H2CO3 level means high pH. High pH means respiratory alkalosis. What are the causes of respiratory alkalosis? It develops when a sufficiently strong ventilatory stimulus causes carbon dioxide output in the lungs to exceed its metabolic production in the tissues. Meaning more carbon dioxide is thrown out from the lungs than is being produced by the tissues, and hence the level of carbon dioxide in the blood becomes less than normal. It may be due to stimulation of the central nervous system, due to pain or anxiety, or due to peripheral chemoreceptors, example hypoxemia, pneumonia, chest receptors, etc. Due to pulmonary thromboembolism. So causes of respiratory alkalosis: respiratory response to high altitudes. Hypoxemia, when a person has climbed Mount Everest, then there is lack of oxygen there. So this leads to hypoxemia, which causes hyperventilation. Hyperventilation causes decrease in PCO2 because the excess carbon dioxide is also going to be blown out, and respiratory alkalosis. These two will inhibit the CNS respiratory center. So they will offset the positive drive of hypoxemia. What is the body's solution to this problem? Renal bicarb excretion will become increased. So this will try to resolve the issue. Increased excretion of CSF bicarb. Hyperventilation now will not be offset because now oxygen is the drive via the PCR. So respiratory alkalosis causes can be hyperventilation, hypoxia, anxiety, high altitude, pregnancy, fever, etc. What happens in respiratory alkalosis? It can lead to seizures, deep rapid breathing, hyperventilation, tachycardia, low or normal blood pressure, hypokalemia. Remember, in acidosis there's always hyperkalemia, and in alkalosis there's always hypokalemia. Numbness and tingling of the extremities. And in respiratory alkalosis, of course, there is high pH, so we call it alkalosis. And why are we calling it respiratory alkalosis? Because the disturbance is in the carbon dioxide level, low carbon dioxide, low PCO2, less than 35 millimeters of mercury. Because excess is being lost from the lungs, excess carbon dioxide is being lost from the lungs. This will lead to lethargy and confusion, lightheadedness, nausea and vomiting. What are the causes? Hyperventilation, due to anxiety, due to fear, panic attacks, mechanical ventilation, etc. So, like we had discussed earlier, in case of acidosis, there is always hyperkalemia, but in case of alkalosis, there is always hypokalemia. Hypokalemia, normal potassium level is 3.5 to 5 milliequivalents per liter. So, in case of alkalosis, potassium level will fall to less than 3.5 milliequivalents per liter. Potassium is an important electrolyte for nerve and muscle cell functioning, especially for the muscle cells in the heart. So low potassium level can lead to a sense of feeling very tired. It will lead to leg cramps, weakness, constipation, and especially it affects the heart, causing an abnormal heart rhythm, which is often too slow and can cause cardiac arrest, or cardiac standstill in systole. What about the ABGs in this case? In respiratory acidosis, because it is acidosis, pH will be low. Because it is respiratory, so PCO2 will be high. And bicarb will be normal in case of primary respiratory acidosis. Respiratory alkalosis, pH is high, and because it is respiratory component, so PCO2 will be low. And in primary respiratory alkalosis, bicarb is still the same, it is normal. In metabolic acidosis, pH will be low, but it has nothing to do with PCO2 in the primary stage. Bicarb will be low, so it is called metabolic acidosis. In metabolic alkalosis, pH will be high and bicarb will be high, but there's nothing to do with carbon dioxide in the initial stages, and so in primary metabolic alkalosis, PCO2 is normal. Compensation of respiratory alkalosis. In respiratory alkalosis, what happens to the pH? pH becomes high, and so it is called alkalosis. Why are we calling it respiratory alkalosis? Because the component that is affected is PCO2, carbon dioxide, and that leads to the consequent effect is on the blood H2CO3 levels. So when the pH is high, H2CO3 levels are low, because there is remember, an inverse relationship between the two. So when a compensation takes place, if this is low, in order to maintain this ratio as constant, this also needs to become low. So the bicarbonate levels start falling in case of respiratory alkalosis in order to bring back the ratio to normal. This is called compensation, and ultimately it will manage to bring the pH back to normal. So the four primary acid-base disorders and their compensatory changes, what do we find in these cases in the ABGs? In primary metabolic acidosis, pH is low and bicarb is low. So, in case of, let's first move to the respiratory acidosis. In primary respiratory acidosis, we find that the pH is low and the carbon dioxide level, PCO2, is high. So what will be the compensation for a high PCO2? Bicarb will also rise. So this is the compensation. In primary respiratory alkalosis, pH is high and the reverse happens to the carbon dioxide, that is PCO2 becomes low. So what will happen to maintain the ratio normal in compensation? Bicarb level also needs to become low in order to keep in line with this low PCO2 to bring the ratio back to normal. So the compensation is a low bicarbonate level. Whereas in metabolic acidosis, pH is low and bicarb is low. So in order to keep the ratio normal, if bicarb is low, PCO2 also becomes low. And similarly in metabolic alkalosis, if pH is high, bicarb was high. So to counter the effect of a high bicarb, PCO2 also level becomes high. So right now we are dealing only with respiratory acidosis and alkalosis and their compensation. So compensation of respiratory alkalosis is through the bicarbonate buffer system in the regulation of plasma pH. What happens is that if there is respiratory alkalosis, so the bicarb levels will become very high, and then the kidney will help out in throwing out this excess bicarb. So this is the compensation for respiratory alkalosis. As you can see out here, homeostasis has been disturbed. There is respiratory alkalosis. So buffer systems other than carbonic acid will release hydrogen ions, and there's renal compensation. Hydrogen ions are being generated, bicarbs are being secreted, and all these will try to restore the homeostasis back to normal. This is the response to alkalosis. Homeostasis is disturbed. Loss of hydrogen ions, gain of bicarb. So there has to be increased bicarb. This will increase the pH, and this will lead to respiratory compensation, and finally it will lead to increased PCO2. Other buffer systems will also work, and there will be renal compensation as well. So this is how compensation takes place. in respiratory acidosis where PCO2 was high. So the compensatory change is increased renal bicarbonate generation in order to keep the ratio constant, increase plasma bicarb, and this can take days to act. In respiratory alkalosis, where there was low PCO2, renal bicarb reabsorption becomes low, plasma bicarbonate level becomes low, and this can also take days. So the compensation in acute respiratory acidosis, where PCO2 has become 10 times of the normal value of 35 to 45 millimeters of mercury. So what will be the compensation? Initially, bicarb levels start to increase. And in acute respiratory alkalosis, where the PCO2 level had fallen 10 times less than normal, then the bicarb level also starts to fall. And in case of chronic respiratory acidosis, we can see that because the PCO2 level was high, so bicarb level has also become pretty significantly high now to bring back the ratio to normal. In chronic respiratory alkalosis, we can find that the PCO2 level was low, and so concomitantly the bicarb levels also become low, significantly low, in order to bring the ratio back to normal. So that was all about respiratory acidosis and alkalosis, their ABGs, and the compensatory mechanism. I hope you have understood everything. If there's still any problem, please do not hesitate to email me. Thank you so much. Assalamu alaikum wa rahmatullahi.